Good afternoon. My name is Professor Mark O'Donnell, and I'm a consultant vascular and endovascular surgeon in the Belfast Health and Social Care Trust, and I'm fortunate to be a visiting professor up in the Ulster University. Today I'm going to talk about therapeutic strategies for the at-risk vascular limb. As part of your master's course in this postgraduate forum, there are certain module aims that are delineated in your prospectus. However, in my lecture today, not only am I going to try and describe how you evaluate a vascular patient, but I want to answer a lot of whys. Why do we do certain things? Why do certain things happen to our patients? There are a number of learning outcomes that we need to evaluate during this lecture. For knowledge and understanding, I wish to apply a systemic understanding of surgical planning considerations for limb salvage, and also want to try and explore critical understanding of the surgical principles that underline my specialty for vascular reconstruction. There are also certain intellectual qualities where you want to be able to analyse and synthesise patient information and then relate this information to the patient themselves and then critically analyse outcomes of clinical approaches. There are professional and practical skills that we all have inherently, but particularly in the 21st century, a multidisciplinary approach is essential to surgical planning, coordination, and best care for our patients. It's also important to utilise critical thinking through research and current literature to appraise ourselves of current standards, but also to continually improve the quality of care that we provide to our patients. There are also transferable skills that I wish to express in this lecture, and that's differentiating what we do nationally in Ireland and Northern Ireland versus the international forum for treatment of clinical lower extremity disease affecting our vascular and diabetic patients. So what is atherosclerosis? Well, it's really hard porridge within the artery, ather being porridge and sclerosis being a hardening or induration within the vessel. But when does atherosclerosis start? Well, it starts really the minute you're born. Enos in 1953, following one of our wars, unfortunately had a lot of battle casualties to examine, and during this process he identified that a large proportion of the young GIs in the American military already had atherosclerosis, and of major concern, 3% actually already had complete occlusion of one or more coronary vessels, and it's important to realise that the mean age of subjects in this study was less than 20. So atherosclerosis, it's a systemic process. It doesn't just affect one part of the body. And for this lecture, we're going to concentrate on how it affects the lower extremities, which is peripheral arterial disease. So what is the definition of peripheral arterial disease? Well, they've evolved over the last 20 years. And indeed, during the defence of my own doctorate, I was somehow caught out with the definition of peripheral arterial disease. I personally use the presence of atherosclerosis distal to the aortic bifurcation. However, at that stage my examiner advised that I had neglected the upper extremities, and therefore peripheral arterial disease is suggested as the presence of atherosclerosis distal to the aortic arch. Different definitions have evolved, and the preferred term is partial or complete obstruction of more than one or more peripheral arteries. Peripheral arterial disease is exceptionally common. It affects 1 in 5 people over the age of 55 years. This is a huge proportion of patients in the Western world, and it's important to realise that we have a more aged population since these publications were produced in 2006. Historical data from the Framingham study also provides that things get worse as you get older, and more recently I've identified that there are higher prevalence of peripheral arterial disease in black patients versus their white and Asian cohort matched populations. So peripheral arterial disease, it gets worse as you get older. It's a disease as you get older, very rare below the age of 30. However, it's very interesting that not all patients will complain of symptoms. In fact, only 1 in 10 to 1 in 3 patients will have symptomatology, but in those patients 1/4 will complain of a deterioration in walking capabilities, and unfortunately there is a proportion of patients that still require amputation. So when we look at the natural history of peripheral arterial disease, well, I worry about not just what I'm doing to the patient during their index admission in my service, I worry about their 5-year outcomes, and that's particularly important for limb morbidity and also best medical therapy for their cardiovascular status. When we look at slides delineating survival over 5-year periods, we can see that there are numerous well-publicised cancers, particularly breast cancer, but I feel in my specialty our patients have a higher mortality rate where peripheral arterial disease has a 28% 5-year mortality rate. This is frightening, and unfortunately in the media we do not have much advertisement for our patients, and I do believe we neglect our patients in that way for advertisement of how peripheral arterial disease affects patients and also how they should be managed in the community and hospital environments. So when we look at the natural history of peripheral arterial disease, I want to concentrate on 1-year outcomes. And 1-year outcomes to me really means what happens to the limb. And in this lecture we're going to discuss limb salvage procedures. So when we look at types of limb ischemia, well, acute limb ischemia is a sudden reduction in limb perfusion. The limb is okay and suddenly it's not okay. Whereas chronic ischemia is what we often more see in the outpatient environment, can classically present with intermittent claudication or critical ischemia. When we look at the definition of acute ischemia, it's really described as a sudden decrease in limb perfusion, which can lead to limb loss. It's usually due to the occlusion of a native artery or vascular bypass, and it's usually less than 2 weeks, but in my experience, this normally happens over a period of hours and certainly not more than a few days. The severity of ischemia at presentation is the main predictor for whether or not the limb can be salvaged. Acute ischemia can occur due to embolic disease, which essentially is the travelling of an occlusive piece of material from one part of the body to a distal part of the body, which is normally of smaller calibre. Common factors include atrial fibrillation, but there are also other factors that can lead to embolic phenomenon, such as atherosclerotic plaques, particularly after interventions, and also septic or neoplastic vegetations. The most common version of acute ischemia, however, is thrombosis within an already diseased blood vessel. Now what that means essentially is that the patient already has some element of disease, and then suddenly that narrowed blood vessel becomes more diseased or occluded, and that sudden occlusion then precipitates the ischemic event. In patients who have chronic disease, they often have developed collaterals, and that does somehow protect them during these episodes. There are also other rare causes that particularly occur in younger patients, such as trauma, drug use, and also following interventions. Acute ischemia classically presents with the 6 Ps. And what I mean by that is that no collaterals occur, there's a sudden occlusion of the main motorway providing blood supply to the limb, and that results in severe pain, a pallor which is clinically obvious with a white limb. The patient is unable to move their limb, they have no sensation, and clearly you would imagine you can't feel any pulses. Interestingly, patients also describe that their limb is so cold, and this is termed perishingly cold. Now, thrombosis, as I've described in the previous slide, does result in perhaps more safety for the patient in that they're not as risk of losing the limb at that stage, but it's still a serious factor. And again, the only reason these patients are slightly more protected is that it's happened over a period of time and they perhaps have developed collaterals, circulation. So how do our patients present? Well, patients have a mottled appearance in their lower limb, which balances in digital pressure. So it's not fixed, it does change. They do have some reduction in sensation and also a reduction in power. So here we can see a picture of a lower extremity which has got ruberous colour in the foot, and when you press on that it does blanch, and that suggests that it's still potentially salvageable. However, as the acute ischemic event progresses, patients develop severe localized or generalized tenderness, and that suggests muscle necrosis, which is muscle death, and that's really irreversible. They then also have fixed skin staining, which when you press on this does not shift in colour in any way. Here we can see a picture affecting the toes, where you press lightly on each of the toes, which will be painful, and there is no shifting of that blue reddish discoloration. There are different classifications of the severity of acute ischemia, and this really all delineates whether or not the limb is salvageable. Rutherford describes stage 1 as a viable limb, stage 2 as threatened but salvageable, and then stage 3 is a fixed ruber's colour, which is irreversible. Here we can see in this slide, we can see the different stages over time periods, where the limb becomes initially cool and pale, and then progresses to a mottled appearance, which is not fixed, then towards fixed blue ruber staining, which is clearly irreversible. One of the things that perplexed me over the years is what actually does acute on chronic ischemia mean? A lot of clinicians do use this term, and my personal understanding is that this is something that's not happened acutely over a period of minutes or hours, but it is a rather sudden and rapid worsening of ischemic symptoms, normally in a patient who is already known to have peripheral arterial disease. Therefore, this usually happens after a few days, up to 2 weeks. It's caused by a patient who already has some disease due to atherosclerosis, and then they have superimposed thrombus causing the occlusion of that vessel. Predisposing factors can occur due to low blood pressure for various means, particularly trauma or from an intervention, dehydration, or even hyperviscosity, often due to neoplastic processes.